So this is my favorite quote surrounding end-of-life care. Life is pleasant, death is peaceful, and it's the transition that's troublesome. And it's that transitional period where hospice care really does its work. And it really, if you look at this and you really think about it, it's a pretty profound, though simple statement. And it really tells you an awful lot about what it is that we do. So I'd like to talk about universal symptoms of end of life. So disease process, irrespective of what leads you to the end of your life, you are almost certainly going to experience all of these to some extent. For some people, it's exceptionally minimal. The one that maybe is least common to be severe would be nausea. But pain, shortness of breath, agitation or delirium, anxiety or restlessness, these are things that are nearly universally common when somebody is dying. And it can be you can have all 5 of these, unfortunately, in large amounts. You can be simply dealing with significant shortness of breath. But ultimately, there is going to be discomfort associated with all 5 of these. And really what we want to do is recognize that that's the case. And that even though somebody may not have had a history of chronic pain, as you are approaching end of life, even if it's a respiratory process, a cardiac process, there is going to be pain and discomfort associated with that transition. And so we always need to keep in the back of our minds that even though a disease process may not point to shortness of breath as one of the primary symptoms, it's almost certainly going to happen because of the natural dying process. So one of the things we're going to talk most about today is pain. And what is pain? Well, it's whatever people tell us that it is. And in particular, hospice providers are really listening to people as they describe their discomforts. And it is whatever they say it is, whenever they're experiencing it. And it's a very personalized experience for people. We have scales that we try to use. We have tried to really give numbers to pain, to give specific words for people to use for pain, but ultimately what we really need to do is just be present and listen and sort of absorb and feel what people are telling us about their discomforts. Why is it so important? Why do we spend so much time talking to families and talking to patients about pain management at end of life? Well, I don't need to tell anybody who has some arthritis, who is fractured a bone, who has experienced chronic debilitating headaches, anything, that pain and suffering really impairs an individual's quality of life. It is depressing. It really impacts your functional status. Can you get up? Can you do the things that you want to do? And when that pain is persistent, the psychological and functional debility that comes along with that is really devastating. Now, hospice patients, we often recognize that the actual cause of that pain, we're not going to be able to fix. However, we can do a good job at minimizing or at least decreasing that pain and discomfort in such a way that we can maximize quality of life. When we're talking about patients who are really at the very end of life, inadequate pain relief really can act as an anchor. It keeps people stuck here. Pain and suffering will get people stuck in that transitional phase of dying. And what does transitioning mean? It's hard to describe. You know it when you see it. I oftentimes will tell people it's like you've got one foot in this world and you've got one foot in the next. And untreated discomfort, and whether that's pain, whether that's agitation, delirium, or respiratory distress, that kernel of agita gets you stuck. It's like an anchor. And your body needs to move on. Your mind, your soul, your energy, however you want to think of it, needs to move on. But you keep getting called back to this world by the discomfort and suffering that is occurring because of your disease process. So it really is important that we focus on good pain and symptom management through the end of life, because without that, you will still die. Your loved one is still going to die, It's just oftentimes going to be a little bit more protracted, and it's certainly going to be more miserable. We don't have any say in whether or not people are going to die. We only have the power to decide how you're going to die. And really, too, you see this earlier upstream, that inadequate pain relief and symptom management can actually hasten somebody's death. There's this pervasive myth that using narcotic medications in particular is going to hasten somebody's decline. And whether you're talking about pain management, whether you're specifically talking about respiratory cardiac failure, good use of narcotic medications oftentimes extends somebody's life, but more importantly, it improves the quality of life that somebody has for whatever time that might be. And so when you maybe have been talking to your other providers, whether you're a PCP, maybe an oncologist, a cardiologist, they are oftentimes very symptom focused, very disease focused, and this is not a knock or a ding on them. This is sort of their approach to management. But hospice experts really are people who are looking at human beings holistically, and we're assessing their suffering holistically. Pain is just one part of suffering. Psychological distress, spiritual distress, physical pain, and all the other symptoms that we've talked about a little bit already really do contribute to what we consider like this whole body suffering. And what we are asking when we're talking to patients, or if we're talking to families for patients that can't answer, we want to learn about those aggravating and alleviating factors. We want to know what medications have they tried in the past, and not just to sort of say, well, we're not going to use that one again, but figure out what was the reason that that particular medication for discomfort didn't work, and have things changed now in such a way that, well, let's revisit that and see if it's something that could be effective. We really want to try to understand too, what's the sort of meaning of suffering, and what are the cultural beliefs around suffering? There really are a lot of feelings about what we should allow ourselves to have as far as symptom management that are based on personal beliefs and cultural beliefs. We'll talk about that a little bit in another slide. And like I mentioned before, we want to know how is this pain, how is this suffering affecting your quality of life? Because ultimately, even though hospice does work within the space of people who are dying, hospice's job is not death. Hospice's job really is promoting quality of life in people with life-limiting illnesses. And I can't really stress how important that fact is. And so when we're talking about these medications, oftentimes we have people or families with a perception that we're just trying to give you medication so that the end of your life can come along sooner and maybe you'll be a little quieter. Nothing could be further from the truth. That is sometimes part of what we are doing based on where somebody's at in their trajectory. However, good hospice care really is all about maximizing quality of life through management of symptoms. When we're talking to people about pain in particular, sometimes people really can't use that word pain. It's a mental block. They don't want to admit that they're having pain. But if you give them words, other words used, discomfort, soreness, aches, and if you kind of find a way to say, well, you'll ask somebody, what's your score on a 1 out of 10? And they'll say, oh, I don't have any pain, or I'm not uncomfortable. And you'll say, well, how far can you get up and walk before you become uncomfortable? Like, oh, I can't hardly sit at the side of the bed, it hurts so much. So there are different ways to approach assessing how somebody's feeling. And really, this bit of our culture really prizes stoicism and toughness. And when I say that, our culture, I'm speaking, specifically, our good Yankee, selves here, where we really do try to tough things out, and asking for help, allowing relief can be seen as a weakness. And I really have this impression that sometimes people think we're handing out awards for suffering. And I try, when I'm working with patients and families, to sort of bring a recognition that it's okay to not want to hurt anymore. It's okay to be sick and tired of being sick and tired, and that asking for help, asking for relief is not a sign of weakness at all. It can be really hard to overcome, but when we do that and then we get some improvement in suffering, sometimes it means you can get out of bed and walk around. Sometimes it means you can at least be present and not so focused on hurting or breathing that you can have a conversation with your loved ones. These are really the goals, and trying to help people understand that it's not just about giving you medications and knocking you out, right? And that's really, one of the pervasive myths about hospice care and narcotic medications in particular is that they are these all-powerful treatments that once you take them, you're immediately going to be sleepy or you're immediately going to be confused. And it's just abjectly and factually untrue. But that doesn't counter other people's experiences with these medications. And those are the things that hospice providers really need to do, is provide education and clarity and context to people's prior experiences with medication management and what things are going to look like now. So common reasons why narcotics aren't used. We've already started addressing this, but these myths about morphine and other narcotics are just rampant. They are no more powerful, no more, people give them power in their minds that they just don't have. There's a lot of fear in our society right now about addiction, about loss of control. And that fear of addiction is something that obviously we see in the news, we see around us, the tragedies that narcotics and other drugs have just brought to our community is really powerful. And it's easy to see how people get into their heads about that. But ultimately for our patients, addiction is just not a realistic concern to have. One can become dependent on these medications in order to feel comfortable. But people are also dependent on blood pressure medicines to not have strokes and die. People are dependent on inhaled medications to treat their asthma. So dependence is not a negative thing. If you need to have regularly scheduled narcotic medications to treat cancer-related pain so that you can get up and go out on the porch and eat dinner with your spouse, or you can get in the car to go see one of your grandkids' games, I would posit that dependence is not such a bad thing. The fact that we are able to do that for you is really the primary goal. Again, I keep saying this, that's the primary goal of hospice. A lot of people of a certain age, their experience with hearing the word morphine may very well be with a parent or a grandparent who went into the hospital, and we're talking decades ago now, without a lot of explanation as to what was happening at end of life. And the doctor may have come out of the room and said, we're going to give your mom morphine, or we're going to give your grandmother morphine, and without really explaining why and how. And then that connection with the doctor gave them morphine and a day later they were dead. That's hard. We really got to work to help people understand why it was appropriate to use that medication, but why it would have been really helpful to help you understand what it meant and how it worked. There is, for patients who can't communicate well with us, we want to think people with advanced dementia, people who have had really devastating strokes. You have a very difficult time hearing from them directly how they are feeling. And so patients and family members sometimes don't recognize their own or their family's nonverbal cues of distress and suffering. That can be tension in their extremities, grimacing, anxiety, even nausea related to anxiety can be a sign and a symptom of suffering or distress. Respiratory distress sometimes can be difficult to parse from somebody's chronic respiratory failure. And again, this is another part of what hospice brings to the table, where we want to help people understand what are the other ways that people can express signs of pain and distress. There is still a lot of difficulty sometimes with caregivers, and this is families, our own CNAs, the patient's other providers in the community really bring their own beliefs about pain and symptom management to the table, and it can cloud their own judgment. And we see this probably more with families, with caregivers, loved ones who have their own feelings, not only about the impending loss of their loved one, they have their own feelings about medications. And when you have an amalgam of all those concerns, it sometimes ends up as a really big barrier to good symptom management. And it's something that we can help explain. So common medications that we use with hospice patients, again, this is not exhaustive. This is really just some of the very basics that we bring to the table. And the reason that we have this sort of small toolbox, if you will, is because these things just work. So common pain medications, narcotic medications, morphine, Dilaudid, fentanyl will almost universally be as a patch that you can wear. And that is very convenient for some people because you only change that every 3 days or so. We have a lot of patients come to us already on oxycodone. Brief word on oxycodone, it's not a very good pain medication. The side effect profile of it is significantly more troublesome than morphine or Dilaudid. And again, speaking about some of the myths around these medications, people will say, oh, they're on oxycodone and, that's so much better. I'm just glad they're not on morphine, which when you understand the pharmacology of the two doesn't necessarily jive, because if you want to talk about milligram per milligram, the oxycodone is 50% more potent than morphine. And so there's the amounts and the frequencies of these medications are really not the important part to get wrapped up in. It's the effects of them. Now, we use narcotic medications, obviously, for pain, but it's also one of the two pillars of management of people who are having shortness of breath for whatever reason, whether it's pneumonia, whether it's chronic respiratory failure from COPD, or even congestive heart failure related respiratory failure. I think it's really important to add to this list, though, of narcotics, the fact that continuing to use things like Tylenol and Motrin, especially for certain kinds of pain, bone pain, and any kind of pain that whether is edema or swelling that could be a component of what's causing the discomfort. Tylenol and Motrin, ibuprofen continue to be fantastic adjuvant medications to keep going. Even when somebody is on high dose narcotics, those medications can bring a lot to the table. One of the other things that we would use along with that would be things like steroids. That goes by the wayside sometimes. Dexamethasone or Decadron, prednisone can be really good additive medications to these narcotics as well. The other one that's not on this list right here that I probably should add is methadone. Methadone is a pain medication that has a lot of negative connotations in the community simply because it is mostly associated with people with prior drug abuse issues and their recovery. It is a fantastic pain medication that works in very different ways from these other narcotics. And people who are having complex pain issues, it can really bring something else to the table as well. To be perfectly blunt, it's something we probably here don't use as much as we should, although there is always an opportunity to improve. And this is something that I'm definitely, as a clinician, trying to bring to more of my patients when it looks like it's appropriate. Management of anxiety and restlessness, we lean primarily on Ativan or Valium. So Ativan is lorazepam. Valium, I think most people know by its trade name. Those are shorter acting medications that work to calm down that fight or flight response. So I kind of look at anxiety existing as sort of two different things. There's anxiety about, did I leave the toaster on when I left home this morning? There's anxiety, I'm worried about how my spouse is going to support herself when I'm gone. But then there's anxiety that is that deep-seated evolutionary response to pain and distress, which is that fight or flight response. That can't be soothed. You can't be reassured about that. The only thing that's going to stop that vicious circle is going to be better living through chemistry. Fortunately, these medications work really, really well when they are used in the appropriate amounts and the appropriate frequencies. So Ativan and Valium are our two go-to for our hospice patients. We know their effects very well. People tolerate them very well. If you are in healthcare, you know that there really is a practice of avoiding any of these for geriatric patients, older patients. And there is good reason to think about being very mindful when you use those. However, when we're talking about hospice patients, we are really talking about folks who are at a point in disease process where some of the other concerns and worries, we are much less likely to adhere to those. Now, if somebody has an opposite reaction to the Ativan, Valium, or Xanax, then we can try one of the other drugs in the class. And oftentimes it is something that we can find a medication that will work well. But I just did want to address the fact that as hospice providers, we know about all these other rules of practice and things that you usually want to avoid. But we are expert in understanding that some of these things can still be used well. We just know how to watch out for the negative side effects and what to do if they occur. So the next medication on this list is Haldol. And again, anybody who's in healthcare has probably heard nothing but horrible things about Haldol. They got a terrible rap, I guess probably late 90s, early 2000s. With a lot of reports of it being used as chemical restraints in nursing homes. I'm not going to go into that, whether that was right or wrong, because it's immaterial to this discussion. But Haldol is an old school antipsychotic. It is exceptionally good at managing agitated delirium, irrespective of the cause. So whether it's dementia, whether it is related to end-stage liver failure, end-stage renal failure, lack of oxygen because of respiratory failure, it just doesn't matter because it works really at sort of the most basic part of the chemistry that promotes agitation. For the same reason, it's really good at managing nausea as well. The myths about Haldol is, you give somebody Haldol and it just knocks them out. It is absolutely untrue. That is not the way Haldol works. If somebody becomes somnolent, sleepy, nearly unresponsive perhaps after taking Haldol or being given Haldol, it's almost certainly because they have been either agitated and awake for hours and hours and hours or days at a time sometimes, or they have not really been able to, even when they are asleep, have a resting of the mind. And so when you give somebody Haldol, if the sort of seeming immediate reaction is that they are knocked out or they fall asleep, it's because they have been physically exhausted from whatever process led to them requiring it in the first place. This is not something that we just use willy-nilly. So when somebody needs it, there's a very good reason. And use of Haldol for nausea is, the reason that it works so well is very much the same as it does for agitation and delirium. It works in that part of the brain that all sorts of things that cause nausea, from your body, the information, it works right at that point. We do use other anti-nausea medications, but a lot of those actually cause drowsiness, can cause dry mouth, have some people get a little squirrely, a little restless, a little agitated with those, whereas Haldol just does not have any of those same effects when we're using it the way that we do. And the dosing on this, again, with these medications, dosing and frequency is not so much important as the results, but for your own edification, for people listening to this, the doses of Haldol that we use that are effective for this are tiny as compared to what you might receive if you were in a hospital being treated for, a psychotic break or something like that. So it's another medication with a really bad reputation, both in healthcare community and even a lot of lay people have heard about this and are very worried about it. A quick note too about this, people with Parkinson's disease, their physicians have rightly told them throughout the course of their treatment to avoid Haldol if it was ever offered to them. However, by the time we're even thinking about using that for people with Parkinson's patients, the reason to be concerned about that is no longer pertinent. And use of Haldol for management of associated symptoms really is appropriate at that point. And the last bullet here, the very best treatment for shortness of breath is a combination of morphine and Ativan. So people with end-stage respiratory failure, in particular chronic obstructive pulmonary disease, COPD. The primary symptom of that disease trajectory is profound shortness of breath. Morphine and Ativan used in concert sometimes are absolutely life-altering for patients, but it's very difficult to get them to accept these medications for some of the reasons that we've already talked about here. But morphine, there's some parts of it where we're not 100% certain how it works, but the working theory is that the parts of the brain that trigger some of the sensation of air hunger and distress are masked or fooled by the presence of morphine being used. This is something that the Ativan also helps with, the second part of that circle. We sort of talked about that fight or flight response of anxiety. And when you've been short of breath, think about if you've been underwater for a second longer than you care to, maybe at the ocean, you get tumbled by a wave and you're starting to get that little tiny bit of panic. Well, imagine that panic being much more full blown and persistent, even when you're breathing. And that is really what dyspnea, that awareness of shortness of breath, that's what that can feel like. And people get used to that. It's sort of like slowly turning the thermostat up in a room. Next thing you know, it's 85 degrees and it doesn't feel all that hot to you. Well, same with the people who are living with end-stage respiratory failure. You and I can see how hard they're working, but they don't necessarily perceive that. Profound shortness of breath and dyspnea can be significantly limiting functionally. And while using morphine and Ativan together is not going to cure the problem, if you could barely sit up at the side of the bed beforehand, but now you can walk to the bathroom instead of using a bedside commode, that's a pretty significant improvement. And that really is what a combination of using morphine and Ativan can bring to the table. You know, morphine with the ability to sort of kind of tone down some of this response, it opens up the vessels in the lungs and the heart, improving delivery of what oxygen there is in the blood to organs. And then using the Ativan or one of the other anxiety medications to sort of put the kibosh on that fight or flight, it can really improve functional status for somebody. Again, these are not miracle workers. They aren't going to take somebody who was bedbound and allow them to go walking down the street necessarily, but any improvement can really be very welcome. So one of the questions we get a lot of the times, well, how are these medications given? So the vast majority of hospice patients are at home, or home is wherever that is. That could be their family home, it could be a nursing facility, assisted living facility. It's not ideal, but we take care of homeless individuals. You know, we find a way to make these things work. But if you're thinking about, again, home, nursing home, and physical spot, usually hospice medications are given orally. And we can do pills, we can do liquid versions of a lot of things for people who are having some difficulty swallowing. And those liquid versions actually will usually absorb very well in the mouth. So even if somebody can't swallow those, the medications can get into your system pretty readily. We do administration of those same sorts of medications rectally as well. There are very few medications that cannot be given rectally. And we do this via a tube that we call a Macy catheter. Now this sounds a whole lot worse than it is, but it's a very thin tube that is placed into the rectum. And in that space right there is incredibly well served by blood vessels. And medications instilled in that area diffuse very quickly and are systemically available not a whole lot less rapidly than when we use IVs or subcutaneous injections of medications. So obviously, if we are doing injection medications, we would generally be thinking about that patient needing to be someplace like the Gosnell House. However, we can do continuous IV medication administration for things like pain medications at home, where the patient has an indwelling catheter, a large IV, or sometimes they've already got a port from prior treatments that they've had, and we can access that port and do a continuous infusion of pain medication, either with or without a button for the patient to dose themselves. And that can be done at home. We can have that with somebody at home so that they can manage that appropriately in the space of their choice. So why do we use the medications that we use? Well, we've talked about this a little bit already. Our toolbox is pretty small by design. It's because that you can have all these specialized treatments, but ultimately what we're looking to do is tackle things at the most base part of the problem. The medications we use are morphine, Ativan, Haldol, a few of the others are actually recognized by the World Health Organization as essential medications. And when they are doing outreach across the globe, those are the sorts of things that they always want to have on hand, simply because they can treat symptoms of just about any problem that might come up. This is, obviously not going to fix somebody's congestive heart failure, but if you are in crisis mode and managing things, then it's very effective. These medications in our state and around the country are widely available. They're easy to get, they're easy to use, and they're really effective. So that's a great way to sort of qualify the medications that you want. Symptom management, in summary. So our philosophy in hospice really dictates that all these decisions that we've been talking about really need to be made in concert with understanding what the patient's goals are. And ideally, they would be simple and effective. So when we talk about what patients' goals of care are, we really do want to understand what is it that you want from your care right now. Hospice patients still need medical care. It's just medical care that is aimed at, or where success is measured in a very different way, right? And providing, our skilled assessment of suffering and then education for patients and families is really just as important as the actual management, because we can't do anything to help unless we have buy-in from the patient themselves, and quite honestly, the patient's families or their caregivers, whichever sort of amalgamation of that might be. We need them to understand and be on board with the plan as well, because at some point or throughout most of their hospice care, the patient themselves may not be able to make those decisions on their own. And we really do rely on the other important people in their lives to help guide us with or making a plan for these things. And again, symptom management should be about promotion of quality of life for as long as it's possible. And if every good hospice provider, that's what they're trying to do, with the understanding that symptom management at end of life is going to be a big part of what we do. And so I'm going to close the lecture part of this with Marcus Aurelius. Death, like birth, is a secret of nature. And this really is the truth. I've been doing this for over 12 years now, day in and day out. And though certainly I have accumulated a lot of experience and a lot of knowledge about this, I feel like there's just as much I don't know about what's happening in this space as I do know now. And I'm never going to learn it all. Each person is unique, each experience is unique. But I feel very privileged and really grateful to spend this time with people and to bring to bear some of our expertise to make it a little bit easier for them.